love what you're describing, because in the scenario that picture that you painted of what goes on in a nursing facility, I've witnessed it for many years, firsthand, as I would do wound care rounds for years. That was my specialty. And what you said, it's easier to keep the patients under observation. They get them dressed. After they eat, they all sit around the common area out in front of the nurse's station, and like you said, they're dozing, they're drooling, but they're just almost in this constant state of sedation, whether it's too many meds in their system or if it's by design. So my question for you is, like I said, I love what your concept and what you're doing, but I just have, it's a numbers game though too. How do you have the manpower to address so many of these patients? Because you got 100 patients in a facility, let's say. How is it physically possible, or how are you all able to manage these patients with that lofty goal that you described?
Can I just put an addendum on that question?
Yeah.
Because we're about to get into a territory that we've talked about before on this program, not to mention my podcast, and that is the appropriate use of mid-level providers. And my takeaway from my previous conversation with Pari was that is exactly what he did. And it's a great statement to the reality that I don't think there are many physicians that want to get rid of the mid-levels. It's a matter of appropriate usage. And I'd like to hear Pari talk about that a bit.
Yeah.
Well, and what you said, Randy, I mean, for his model, for Pari's model, it sounds like, how else would you be able to do that with the number of nursing facilities and stuff without enlisting other physicians of Dale's background or whatever to take part in your care? You almost have to use mid-level providers.
Well, exactly. And I think you see that in practically all specialties. There's more work than can be done with the physician alone. But the trouble comes when the mid-levels are left unsupervised for whatever reason, and typically in the conversations that I've had with other physicians is the reason for that is that the hospital hires the mid-levels and just lets them go on their own, and they don't really answer to a particular physician. And that's what I think is magical about what Pari has done. So we get a chance to talk about it.
And before we let him answer too, I see a parallel with what happened in the wound care community too.
Oh yeah.
Because 20 years ago, we just did not have enough providers. And we had this onslaught of patients coming as the population aged and our diabetic population was growing. And we're still not there, but it's gotten better because we recognize the problem and people have been trained now. So I think, Pari's got a couple things working in his favor. Number one, he's young enough that he can continue this constant training, and his model is conducive to, to bringing in people and being able to get those providers up to speed. So anyway, sorry, Pari, I didn't mean to hijack your answer.
No, that's great. No, it's very, very clear that there is a lot of interest in knowing how this works. So that's great. Good to hear that you're all interested. So first of all, let me take a step back and tell you that it's not only the nursing home, but overall the need for psychiatry has grown tremendously over the last few years, decades. First, because of the awareness is better. People are more accepting of psychiatry, more reaching out to them, and are more accepting of taking medications when needed. So that's one aspect. But the other aspect is it's sad that the amount of stress, the lifestyle, the challenges that we face, and now with the COVID challenge, such an emotionally stressful time with mental health pandemic inside the main pandemic is there. We all are faced with increasing challenges, and our schooling really does not prepare us to how to enhance our emotional well-being and give our psychiatric coping skills. It tells good about analytical skills, it improves our intellect, but the emotional intelligence and wisdom is really, there is no training for that. It comes from our parents, we comes from our community surrounding teachers, we absorb them, we learn from them, but there is really not a formal training into that. Really, I don't use the geographical knowledge every day, but I have to really use the emotional coping every day. And it's so sad that in the education system, we don't specifically teach the psychological well-being and all that. And that needs to be something addressed in future. But because of this, there is overall increase in the need for psychiatric services, which is a sad fact, but it is a fact.
Right.
And geriatric population is not excluded from that. So there's one side that there is increasing need, and there is a less willingness to accept human sufferings as a part of normal life. Now everything needs a pill and needs a solution. So that's another reason that mentality has increased the trend towards going to psychiatric help. So on one side, what I'm trying to do is to offset that by this meditation, wellness approaches, and giving enhancing each individual to improve their natural resources, that they don't have to go after psychiatric help. But let's say they have to go, then there is no shame. There should not be any delay in seeking treatment when they have to go on this side and get the help. We are on this side also, we're on that side also. So we promote the whole spectrum, wellness spectrum plus treatment of illness spectrum. So that's one side, the need for psychiatric services growing up, and geriatric population is not an exception. Actually, they have more challenges than the general population with the age, with the decrease in their ability to be mobile, decrease in their vigor, vitality, facing the medical issues, being on medications which have side effect, the other medical medications which have side effect, pain, hospitalizations. You have been, if you're in nursing home assisted living, then you have further restrictions on things that you can do, limited contact with family, uncertainties about future, losses, losing friends and families just because of aging. And the aging brain, which has its toll on the coping skill itself. And then dementia, it has its own full spectrum of effect on our behaviors and coping skills. So the geriatric is even more vulnerable than the general population. Overall, psychiatry is growing, geriatric is even more growing. So there is a lot of need coming from that. Now, how to meet that need, how to meet that demand is the key here. Well, one thing, psychiatrists are rare species. They are not available. They are in high demand just because there is just not enough psychiatrists then to meet up with this need that is building up. And it's going to continue to grow at least for the next few decades until these wellness approaches kick in and everybody has more resources within. So psychiatrist is not an answer. To hire a bunch of psychiatrists, provide services is not an answer because they are just not available. Everyone is busy with so much work is there. So I had no option other than building the workforce through mid-level providers. Now, the good thing is there is a psychiatry board certification for a nurse practitioner. It's a 2-year or sometimes 1-year course that they have to go through and get the board certification. They have rotations. So that does equip them with abilities to treat mental health properly. But even with that, nursing home is such a specialized field that when I hire anyone, whether it is a board certified or whether it is not board certified, but experience in psychiatry, I literally have to put them through a very strong training program. So it's right that you have mentioned that if they're not properly supervised, they cannot be a good provider because they have a broad range of training in short time, particularly the physician assistant. They have to do so many things in 2 years. I don't see that they're learning everything. So their real training happens at the job. So if the employer, if the person who is running the company is a physician in that specialty, and has the protocols in place and understands the importance of training, then the providers can be really useful. But some places where they're just hiring mid-level providers, not giving them enough training, just putting them directly in front of the patient and not supervising, then I don't think that's a good model. That can actually cause harm to the patient, because then providers are learning through their mistakes.
Yes.
Who is the victim of those mistakes? Patients. So we really don't want to go that route. So what I have done is I have created protocols, manual that I have written up based on my experience. This is to do when this happens. This is how you can approach that type of category of patient. This is how you can approach. So when they come, they go through the online modules, then they have the manual that they have to follow, which I recommend them to keep next to them all the time. But also I have incorporated those training blurbs into our EMR. So if they select that patient is having these types of issues and they're having this, if that is their assessment, then these are the recommendations coming from me, that this choose from this class of medicine, choose this medicines or that medicine, use this dose or that dose. If this is the situation, get rid of this medicine, that medicine. So that all those protocols are next to them in EMR, guiding them, guiding their thinking process, and also helping them come to a right assessment, right conclusion. And then we have a backup monitoring system. So yes, we on the front end, we have this online training, and then these manuals and protocols, and then webinars and ongoing supervision on phone and discussing the difficult cases. But on the back end, we're monitoring the outcomes. Are the patients improving? Are the medications going down at the facility level? Are their safety profile improving? How many Baker Acts are going on? Baker Acts means involuntary psychiatric hospitalizations in the state of Florida. It's called Baker Act.
Yes.
So how many Baker Acts are going on? How many times patients are getting hospitalized? How many times we are identifying the wrong diagnosis and correcting the diagnosis? So all that monitoring is going on the back end. I have 45 right now, as of today in June 2021, 45 employees in India sitting doing all this back-end work, finding what is going on in terms of outcomes and whether they're doing good job or not. So then we find out these providers are doing good job, these providers need more training. Let's focus on them, let's reach out to them, and let's remind them that your outcomes are not ideal. This is where you need to go, and we reward those who are bringing those outcome, and we don't reward those who are not bringing the outcome, and then they have to earn those rewards by showing the improvement. So after all, money speaks. We give financial rewards to those who are performing better, and we don't give to those who are not performing better. So the entire system was developed to more kind of a automation mode, so it can run itself and bring the results. So any new provider come, whether they're good trained or not good trained, they go through this, they come to some certain standard, and after that they continue to improve over the time. And that has produced such a best results that our company has grown so fast over the last few years and few months, that in last 2 months I had to hire 10 providers and train them. Right now 10 providers are in training right now just to meet the need. So
good problem to have.